Next, with some practical points about checkpoint inhibitors, we have Becky Champion from the Norton Cancer Center here in Kentucky.
Thank you. Thank you all so much. As Dr. Emmons mentioned, I will be talking about immunotherapy, some of the new formulations that are available for our patients, and some practical management strategies. Our objectives today, we will review recent updates in immunotherapy administration, including the new subcutaneous formulations. We will summarize some general principles for immune-related adverse event management and discuss some management strategies when corticosteroids are insufficient. But first, I think we need to talk about the growth of immunotherapy. While it's true that we've had high-dose IL-2 since the 1990s, our first modern-day immune checkpoint inhibitor really started with ipilimumab in 2011. And if you look at the growth that we've seen over the last 14 years, it's really been exponential. We have over a dozen new agents that are available with over 80 new indications. We now see these agents in the neoadjuvant or the adjuvant setting, as well as the metastatic setting. So it really affects a whole variety of patients in both solid and hematologic malignancies. I put this slide together about 2 weeks ago, and I quickly realized that the FDA has already approved a new agent. Pempulimab was FDA approved for the treatment of patients with nasopharyngeal carcinoma. So as of today, this slide is already outdated. And we also have new formulations that we have to offer our patients. The subcutaneous formulations that were approved last year are really going to be a game changer in terms of how we treat patients. There are several different advantages when we talk about the sub-Q formulations. The first, most obvious, is a shorter administration time for our patients. Instead of giving traditional IV infusions for patients that maybe take 30 or 60 minutes, we can now offer these over 3 to 7 minutes. There's also less need for venous access. This may be of clinical importance for your patients who are hard sticks or who don't have any central access. And also that could potentially mean less chair time. So I have my nurse manager here, and she can attest that some days by 10 a.m. we're already on a wait list. So to be able to have less chair time and increase that chair utilization without having to increase the number of chairs in our clinics is going to be significant. And then patient satisfaction across multiple clinical trials, just because of the inherent nature that we don't have to start IVs on these patients and we don't have to always get these hard sticks, that patient satisfaction we may see increase with these agents. There are certain disadvantages, which include injection site reactions. These were seen in higher rates in the clinical trials. Again, these are mild, usually self-limiting, but this is an education point when we talk to our patients about these options. And then finally, the cost and reimbursement considerations. We have to be mindful of the fact that with these newer agents that may impact, not only are you able to bill for an infusion, does the reimbursement look different if we're choosing the sub-Q or the IV formulation? So looking at the sub-Q formulations, atezolizumab was FDA approved in 2024. And it's across all indications of IV atezolizumab. So this would include our non-small cell lung cancer, small cell lung cancer, as well as hepatocellular. FDA approvals based on the MSIN-001 study that looked at about 400 patients with locally advanced or metastatic non-small cell lung cancer. The primary outcome was really PK in nature, looking at atezolizumab exposure. And looking at the Cmax and the area under the curve, there were no significant differences between the IV and the sub-Q formulation. And looking at the secondary outcomes, which included overall response rate, progression-free survival, and overall survival, again, no notable differences between the two. Nivo plus hyaluronidase was FDA approved in December of last year. This was FDA approved in combination, with all the solid tumor indications of nivolumab. This would include monotherapy as well as in combination with chemotherapy or cabozantinib. It's important to note that this is not approved in combination with ipilimumab or for any of our patients with hematologic malignancies. This FDA approval was based on the CheckMate 67T study that looked at advanced or metastatic renal cell carcinoma patients. Again, the primary endpoint was that nivolumab exposure, no significant differences when they looked at Cmax or area under the curve between the IV or the sub-Q formulations. Secondary endpoint included overall response rate, no notable differences were observed. So in looking and comparing the sub-Q formulations, I just wanted to highlight a couple of the differences. You can see that the Atezo sub-Q dosing is 1875 milligrams given as a sub-Q injection every 3 weeks. We have a little bit more dosing flexibility when we look at nivolumab sub-Q. This can either be given 600 milligrams every 2 weeks, 900 every 3 weeks, or 1200 milligrams every 4 weeks, depending on what the patients were previously on. Also, in looking at the injection site, the Atezo sub-Q is only given in the thigh versus the nivolumab sub-Q can be given in the thigh or the abdomen. And looking at the actual injection, the Atezo is 15 mLs given over 7 minutes. The Nivo sub-Q is anywhere between 5 to 10 mLs, and this is given over 3 to 5 minutes. Both of these can be given with a butterfly set or a 23 to 25 gauge needle. And not far behind is Pembro sub-Q. This was a phase 3 study that was published earlier this year. This looked at newly diagnosed metastatic non-small cell lung cancer patients and randomized them in a 2-to-1 fashion to receive either doublet chemotherapy with Pembro sub-Q or with Pembro IV. The primary endpoints, again, were PK as well as steady state concentrations of Pembro. And looking at the results, the mean injection time was about 2 minutes. PK endpoints were within the established bounds for Atezo, and the similar efficacy outcomes and safety measures between 2 arms. It is anticipated that Pembro sub-Q could be approved as early as fall of this year. But it doesn't matter if we give these agents as an IV or a sub-Q infusion. Adverse events management is still very important in how we manage these patients. And as we look at this, we just really need to focus on our shift from chemotherapy to immunotherapy. All of us are very familiar with chemotherapy. We know that these attack fast-growing cells. These could be normal, healthy cells, and we're very familiar with how to talk to patients. We talk to patients about nausea, about hair loss, about mucositis, and diarrhea. But as we shift, we need to think about the fact that immunotherapy works so differently. It's not directly attacking the cancer cells, but it's lifting that veil that helps these cancer cells hide from the immune system. And it's that same mechanism that works so well for different cancers that makes these adverse events so unique and specific to these drugs. So in looking at some of the general principles of these immune-related adverse event management, number 1, always rule out other causes. Remember that these are sick patients. And a lot of these adverse events could mimic other diseases or disease progression. So it's always important that we're looking for other causes of some of these adverse events. We always want to make sure that if we are using steroids, we're going to use the lowest effective steroid dose for the shortest duration possible. These treatment strategies are not benign, so we need to be mindful of how much steroids we're giving patients and how long they're going to be on them. It's also important that we increase the monitoring frequency for patients. I know in clinical practice, sometimes I will see that maybe we'll just hold the dose of immunotherapy and we'll bring the patients back with their next scheduled visit. But we have to ask ourselves, is that really what's most appropriate for these patients? Should we increase that monitoring? Do we need to see them more frequently? And then finally, escalate treatment early if needed. Steroids are great. They work well for most of our patients, but if they don't work, what do we need to do for them? And also just to focus a little bit on grading. So grading is so important when we talk about immune-related adverse events because it drives not only the treatment strategies that we're going to use, but it also helps us to determine when we're going to hold therapy and when we can continue therapy. In general, for patients who present with grade 1 immunotherapy toxicities, which are usually mild, immunotherapy can be continued. For patients who present with grade 2, treatment is usually held, and we would consider starting prednisone for those patients, anywhere between 0.5 to 2 milligrams per kilo per day, depending on the severity. Now, there are certain exceptions to that, which may be a macropapular rash or thyroid abnormalities. The guidelines do recommend that we could potentially continue treatment in those patients. For your patients that present with grade 3 or 4 toxicities, we would consider holding or discontinuing immunotherapy in those patients. These are your more significant, potentially life-threatening toxicities, and these need to be taken very seriously in our patients. And at this point, we would consider escalating corticosteroids. So if we had these patients on PO prednisone, is it time to escalate to IV therapy? Do we need to consider any specialty consultations? Are patients with pneumonitis? Is it time to consult pulmonology? And do we need to consider other immunosuppressive agents? And the recommendation is that we continue to treat these symptoms until they resolve until a grade 1 and then taper over several weeks. Again, in clinical practice, we may be tempted to just give patients a Medrol dose pack and say, go ahead and take this and I'll see you back in a couple of weeks. Is that most appropriate for patients? Do we know that that dose is going to treat those symptoms that we saw? Do we need to evaluate those patients before they start to taper? So as I said, most immune-related adverse events are managed with steroids, but there are some cases that are more severe or considered steroid refractory. So in the next few slides, I just wanted to highlight a couple of the organ-specific treatment strategies that may be available for our patients. And looking at skin, so again, most of the time we can manage patients with either topical or systemic steroids. For your patients that have pruritus without a rash, potentially we could use something like gabapentin or pregabalin. These are GABA inhibitors, and these work well when patients have that pruritus. We could also consider IVIG therapy for these patients. And there's a couple of biologic agents that are also available, dupilumab and omalizumab. Dupilumab is a monoclonal antibody. It is directed towards IL-4 and IL-13 to help with that itch-scratch cycle that we can see in patients. Omalizumab is another agent. This blocks the interaction between IgE and mast cells to help prevent that mast cell activation and potentially would be an option for our patients who have severe toxicities. And looking at some of our second-line strategies for diarrhea and colitis, for those patients who have mild symptoms, we may potentially be able to manage them with budesonide, which is a non-absorbable steroid. For patients who do have more moderate to severe symptoms, that's when we would lean on some of our other biologic agents. Infliximab is usually our go-to. It's a TNF-alpha blocker, and it's used pretty consistently for patients who are steroid refractory. Usually 1 to 2 doses at 5 per kilo is enough to manage patients who have diarrhea or colitis. Vedolizumab is another option for our patients. This is an integrin inhibitor that is typically thought to be gut selective, so less immunosuppressive in the system. Tofacitinib is another agent. This is an oral JAK inhibitor that inhibits multiple cytokine kinase pathways in these patients. And then ustekinumab is a blocker of IL-12 and IL-23, FDA approved for psoriasis, but also for ulcerative colitis, and has activity in diarrhea and colitis as well. And looking at some of the second-line strategies for hepatitis or transaminitis, you can see mycophenolate mofetil is here. This decreases lymphocyte proliferation. Ursodiol may be an option for our patients who have hyperbilirubinemia. It's important to note that not infliximab. Infliximab has been associated with drug-induced liver injury, so it is important that we shy away from that when we're talking about transaminitis in our patients. And as I mentioned before, it's important that we perform liver tests, which include coagulation studies every 1 to 5 days, depending on the magnitude and the rate of change that we're seeing in our patients. And then finally, just a quick word about pneumonitis. Pneumonitis is one of the more severe toxicities that we see. As you can see, IVIG and mycophenolate would be options for your patients who are steroid refractory. Tocilizumab may also be an option for your patients. This is an anti-IL-6 antibody that we typically use in cytokine release syndrome, but may help with that inflammatory reaction that we are seeing in patients when they do have pneumonitis. And then I just wanted a quick word on the risks that are associated with immunosuppression. So these drugs are all wonderful options. They are necessary when we are managing these patients who have adverse reactions to their immunotherapy, but they're not without their own risks, and it's something that we need to be very mindful of. When we talk about corticosteroids, it's important that we consider things like opportunistic infections. Inherently, these put your patients at higher risk for things like PJP, for herpes reactivation, as well as fungal infections. So you have to stop and ask yourself, what does your patient need? How long do I anticipate that they're going to be on these, and what type of prophylaxis should I initiate in these patients? Hyperglycemia is another known complication when we talk about corticosteroids. What does that mean for your patients, especially your diabetic patients? What do we need to counsel them on? We talked to them about gastritis. So what does that stress ulcer prophylaxis look like in your patients? And for patients who are on long periods of corticosteroids, osteopenia and adrenal suppression are also 2 long-term complications that we would need to consider. In thinking about infliximab, there is a risk of infection, including TB reactivation. So it's important that we screen our patients for latent TB prior to starting, if at all possible. It also carries a black box warning for secondary malignancies, including Epstein-Barr lymphoproliferative disorder, as well as lymphomas. Again, trying to be mindful of some of the toxicities that we can see with these agents. And then tofacitinib, the oral kinase inhibitor that I mentioned for diarrhea and colitis, it also carries a black box warning for the increased risk of infections, which include the risk of TB. So again, monitoring our patients, screening them early if possible, can also increase the risk of thrombosis or cardiovascular complications. So this may not be the best option for all of our patients in our clinic. And then also the risk of secondary malignancies. So for most of this presentation, I used the NCCN guidelines, the management of immune-related toxicities. But as you can see, there are several different options that are available when we're talking about different guidelines. The American Society of Clinical Oncology has their own guidelines. So does the Society of Immunotherapy, as well as ESMO. Across all of the guidelines, the principles are pretty consistent. Number one, we need to make sure that we are identifying any adverse reactions early. Number two, we need to manage patients with steroids. And number three, if steroids aren't working for our patients, we need to escalate after about 48 to 72 hours for our patients. And then just one final word, immune-related adverse events can manifest anywhere. We are all very familiar with some of the toxicities, but when I sit down and talk to patients, I always want them to know that these can literally happen anywhere. So if you have a patient in clinic and all of a sudden their blood counts are in the toilet, what does that necessarily mean? We don't typically think of these agents causing that immunosuppression, but could this be an immune-mediated response in the bone marrow that we're seeing? In a similar fashion, we don't typically think of these as causing renal insufficiency, the way that we do with cisplatin or carboplatin. But immune-mediated nephritis is well documented in the literature, and that's also something that we need to consider. So the take-home message is any lab abnormalities, any clinical changes that you see in your patients, all of those need to be evaluated, and we always need to ask ourselves, could this be related to patients' immunotherapy? So just some final takeaways. There are new FDA approvals that continue to expand our immunotherapy portfolio, that steroids remain the cornerstone in how we manage our patients, but it is important that we consider escalating treatment if there's no improvement within 3 to 5 days, and as always, we need to balance our management with safety for our patients. And with that, I will take any questions or comments.
Any questions for Becky?
Yes, sir.
So I have a question regarding your thoughts on infusion and non-oncology infusion places or even at home. So our resources are limited. Cancer patients are increasing day by day. There's always this battle between the infusion case managers and the clinic case managers. You are sending way too many patients. Can some of these patients be done elsewhere? So one, can we, for those select patients, say who has had no reaction for say 6 months or a year and are continuing maintenance treatment, can we infuse them at an outside place? They still it's an infusion center, but a non-oncology infusion center, or even home?
It's an excellent question. A lot of times we are driven by site of care restrictions for our patients. So we have, unfortunately, our hand has been forced pretty early. For most of my patients, if our providers still want to see them pretty frequently, we're still doing it in the clinic. But I have had a couple of patients who, as you mentioned, are on maintenance therapy. They're only seeing their provider every other cycle, and those would be ideal candidates for home administration. Yes, sir, it is. Yeah, site of care restrictions. And it's most frustrating when it's in combination with chemotherapy. So sometimes we will see site of care restrictions where they say, well, you have to get the immunotherapy at home, but then you're still getting an IV component in the clinic. To me, that doesn't make sense, but we do see that. So we do try to push back on those situations. But for patients who are on just single agent immunotherapy, we have started moving our patients home for the exact reasons that you mentioned.
Have you used any tocilizumab instead of infliximab, particularly in like an acute severe setting? Because infliximab's introduction was kind of just serendipitous into this space.
And we have, yes, sir, we have, and good results as well. Mm-hmm.
Any other questions for Becky? Well, thank you for a great talk.
Thank you.